My name is Dr. Vicki Jackson, and I'm the Acting Director of Palliative Care at Massachusetts General Hospital. Palliative care is a medical subspecialty that focuses on quality of life, and we see our job is to help patients live as well as they can for as long as they can. So in this study, what we did when we would see a patient for an initial evaluation is do a comprehensive symptom assessment, asking questions about their experiences with pain, fatigue, shortness of breath, nausea, and vomiting. We would prescribe medications to alleviate those symptoms. We also spent time focusing on how the patient and family were coping with their illness and helping them navigate the medical system and their treatment. In palliative care, we see our job is to help patients clarify their goals and values and match their treatment decisions based on those goals and values. We find that patients who have a new diagnosis of cancer can often be very overwhelmed with the treatment options, the scans that need to be done, other procedures that need to be done, and the patients described it to be really important to have another group of clinicians who were focused on them and their quality of life, knowing that they had two groups of clinicians helping them navigate this illness. So what we would do is help them think through how to be able to feel as well as they can when they were undergoing chemotherapy. We worked very hard to try to treat the chemo-induced nausea and vomiting, also to work with the fatigue that often accompanies these kinds of treatments. We also helped make sure that we were all in communication together, meaning that the oncologist and the palliative care doc and the patient were all on the same page, helping them understand what to expect in terms of their care. One important thing that we found in the study was that patients sometimes would be more forthcoming with bothersome symptoms to the palliative care clinician than they would be to the oncologist. We found that they would be sometimes worried that they would be letting their oncologist down or that their oncologist would stop chemotherapy if they knew that they were having difficult symptoms. Because we weren't writing the orders for the chemotherapy, they found themselves feeling safer to share those symptoms and then get treatment for those symptoms. At Massachusetts General Hospital, our outpatient palliative care clinic is embedded in the oncology clinic, which helped to facilitate communication. We also would schedule the patient's appointments with palliative care on the same day they were seeing their oncologist, which just because of proximity allowed us to connect before or after our appointment with the patient to discuss what was happening in terms of the clinical care and make sure that we were all seeing the same issues and attending to the same issues. We have an electronic medical record which allows us to clinicians to see one another's notes. In this collaborative model with palliative care and oncology care, a significant amount of the time we would see the patients together for some portion of a visit or be able to connect back with the oncologist after we saw the patient because we were seeing patients in the same environment, really helped to facilitate that communication. I think the one important point that Jennifer made, which I'd like to really emphasize, is the common misconception about palliative care and hospice, that palliative care is a service that is available to patients regardless of prognosis, where hospice is a medical benefit provided to patients who have a prognosis of 6 months or less.